Participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8th, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I would like to welcome our panel of witnesses. Appearing as an individual by video conference, Dr. Nikki Matthew, physician. On behalf of the Canadian Centre for Substance Use and Addiction, Dr. Alexander Cottarella, Chief Executive Officer. On behalf of Mums Stop the Harm, Petra Schulz, co-founder. And on behalf of Project Chameleon, Dr. Marie-Eve Morin, General Practitioner, Addiction and Mental Health, also appearing by video conference. Welcome to all of our guests here today. We'll begin with opening statements, starting with Dr. Matthew, please, for 5 minutes.
Thank you for allowing me to come here and speak. I'd like to provide a disclaimer. The views and opinions I express are my own and not attributed to any organization. So I'm an addiction and forensic psychiatrist, and I'd like to talk about the connection between substance use, psychiatric illness, overdose, and violence. And I want to take a case out of forensic psychiatry. So this is John Doe. His father left the household when he was young. He experienced racism in school due to his skin color. He found a sense of belonging in a group of friends that used cannabis. He started using cannabis in elementary school and started to skip school to use with his friends. In high school, he was transferred to an alternative school but dropped out shortly after. He started using opioids with hydromorphone that he bought from the street. Due to his drug use and theft at home, he was asked to leave and move to the downtown east side. To stay awake on the streets, he began to use crystal meth. Roughly 1 year prior to his index offense, he began to experience psychosis with paranoia, visual hallucinations, and heard voices with auditory hallucinations. On the day of the index offense, John Doe was using fentanyl and crystal meth. John Doe heard voices that the victim was going to rob him. As a result, John Doe punched the victim. The victim grabbed John Doe, who was now afraid for his life. John Doe then pulled out his knife and stabbed the victim in the neck. John Doe felt remorse after the event when he was no longer intoxicated and psychotic. John Doe did not know the victim before the event. So when we look between 2017 and 2022, unregulated drug toxicity has become the #1 cause of death among British Columbia youth, and 73% of the youth that had died had received services from the Ministry of Child and Family Development. There was a study called the Hotel Study that looked at the population in the downtown east side, and what they found was that 95% had a substance use disorder, 84% had a mental illness, with 74% having a current mental illness at the time of their substance use disorder. There was also a 45% prevalence of a diagnosable neurological disorder on MRI. So there's a lot of folks out there with these disorders that are brain damaged. Also, with the coroner's report in 2017, what they found was that 52% had a mental disorder. So concurrent disorders, a mental illness and a substance use disorder is the rule. It's not the exception. So there was a study by Kristen Morin, and this was out of Ontario, and what they looked at was adding psychiatric treatment with folks with opioid agonist therapy, so methadone clinics, and they looked at Northern Ontario and Southern Ontario, and what they found was that adding psychiatric treatment decreased ER visits and hospitalizations in both Northern and Southern Ontario, and all-cause mortality in Southern Ontario. There's a lot of amphetamine use among these folks who overdosed in British Columbia. So between 67 and 79% of the people who passed away also had amphetamines in their system. Now, why should we worry about amphetamines? There's been a rise of phenyl-2-propanone meth, which is more potent and more likely to cause psychosis. When you look at the folks with an amphetamine use disorder, 40% will have experienced psychosis. And as their amphetamine use disorder increases in severity, 100% will have experienced psychosis. So psychosis is a neurotoxic event. Initially, they won't be psychotic. Then they'll be psychotic when they are intoxicated, then in withdrawal, and then into times of sobriety. So there's a kindling effect, and this psychosis is more difficult to treat and more severe as use continues. So what would be the recommendations? Well, treating addictions is complicated. The way the opioid crisis has been approached is as if it's an opioid deficiency. So like iron deficiency anemia, if you add iron, you'll cure the illness. Well, Almost the entire focus has been on giving people enough and different kinds of opioids, assuming this will solve the crisis. Opioid use disorder is not an opioid deficiency. Any place on earth that has treated an opioid crisis used multiple approaches where medication was just a small part. We need to look at a wide range of evidence and solutions. It is unlikely we will find a home run intervention. With the varied populations, we will need input from public health, addiction medicine, and addiction psychiatry, among others. We will need to have clearly defined metrics of failure for interventions and be willing to reevaluate those interventions if they do not pass the bar. There is a recent Canadian evidence that treating patients' mental health and addiction issues concurrently will keep the population alive. Psychosis increases the risk of violence 3 to 4-fold, so treating psychosis is important in treating violence. Early access to treatment for concurrent disorders can help change the trajectory of the illness and the associated risks. Clients, especially high-risk clients, need timely access to treatments. Along with treatment, there needs to be stable housing with appropriate supports. There needs to be vocational and rehabilitation opportunities. Psychological therapies are not covered. The intervention with the most evidence for amphetamine use disorder is contingency management, which is psychosocial treatment. There are significant gaps in the criminal justice system, especially on release, and those gaps need to be filled. Providing concurrent psychiatric care to patients with addictions can reduce violence and save lives. Thank you.
Thank you, Dr. Matthew. Next, from the Canadian Centre on Substance Use and Addiction, Dr. Cottarella for the next 5 minutes. Welcome to the committee. Doctor, you have the floor.
Mr. Chair, Vice Chairs, and committee members, thank you for inviting me and the Canadian Centre on Substance Use and Addiction. It was the late Brian Mulrooney who created CCSA through an act of Parliament 35 years ago as a neutral arm's-length agency to provide leadership on substance use health and advance evidence-based solutions. As CCSA's new CEO, I've spent my first year listening to diverse voices on how we need to act to achieve the most impact. As well, I'm a family doctor who's worked across 3 provinces and a territory. En fait, ce sont mes patients qui me rappellent que lorsqu'une personne...
It's the patients who have reminded me that when patients go to the emergency with an opioid problem, they rarely get the support they need. About 1%, it was found in a recent study, that would go to their family practitioner to go for a using problem. For young people, the number of those in therapy has diminished over the years. People come against barriers and closed doors. Some treatment doors have opened, but that has to be opened even further.
Rooted in pain and tragedy, coupled with a deep sense of urgency that has sent people and organizations off in all directions. Countries that have successfully tackled past drug crises have done so not within silos, but with humility and collective whole of health, whole of government, and whole of community approaches. A spectrum of care that includes treatment, recovery, and harm reduction, but that arcs towards improved health is required to reduce risk. This spectrum must also include prevention. In 2011, CCSA published the world's first evidence-based prevention standards. With the emergency declaration first happening 8 years ago, we must think of the lives we could have saved if we had invested. It is why CCSA is committed to building community prevention coalitions. Every community deserves to feel safe, and every person deserves access to the care they need when and where they need it. People want to help each other, and we need to create opportunities for them to do so. CCSA has been working with people with lived experience, families, physicians, police, and communities to move this forward. The real solutions will come from them, and CCSA is committed to using its resources and data to support their collaborations. We're hosting a series of community-level summits on the ground where the issues are felt on strategies to end substance use crises. One immediate outcome has been the establishment of competencies for prescribers of all levels. Our failure to collaborate more effectively amongst sectors strains the broader healthcare system. Harms from substance use cost the country $49 billion, or about $1,300 per Canadian. I'll never forget when I was working in the ER, watching a man lay in pain, waiting for 4 days with a broken hip. His granddaughter never left his side. He didn't get a hospital bed because we had 3 people in our ICU with overdoses that they should never have had, and 2 people waiting for heart surgery for drug-related infections that we waited to treat. There is no turning back. We now live in an era of powerful synthetic drugs that are too cheap to make and too easy to buy, and where data and clinical practice are evolving rapidly. In 2005, CCSA redirected resources in partnership with the provinces, municipalities, First Nations, Métis, and Inuit providers, enforcement agencies, and key federal departments to drive everything we did towards supporting what our communities needed most. The resulting national framework for action to reduce the harms associated with alcohol and drugs was relevant and real and impactful. We collaborated across divides then, and now it is the time for the leaders of our field, myself included, to set the table and work together. The solutions are in the communities, and we need to provide the data, the science, and the resources to activate them. Thank you for your time and for your study of these important issues.
Thank you, Dr. Cottarella. Next, on behalf of Moms Stop the Harm, Petra Schulz, co-founder. Welcome to the committee, Ms. Schulz. You have the floor.
Thank you for this opportunity. I'm a co-founder of Moms Stop the Harm, representing thousands of families across Canada. Most mourn a loved one due to the toxic drug crisis. Many support loved ones whose lived and living experience. Our website includes 600 images of loved ones who have died. Being here today is both meaningful and difficult, as tomorrow is the 10th anniversary of the day when our son Danny died. Danny was a brother, a friend, and a talented chef. Danny is a poster child for failed drug policy. He was on methadone for a while, then abstinent but never stable. In 2014, fentanyl appeared on the market, and he was one of the early victims. There were no warnings, and he did not have access to harm reduction, which could have saved him. Today, almost everyone knows someone who lost a loved one. Those who die include people who use every day, occasionally or just once, like Olivia, a 13-year-old girl from central Alberta who died after using with a friend. We do not know what substance the teenagers intended to use or how much, but unregulated fentanyl killed them both. The increasing death from the toxic drug supply is driven by prohibitionist policy decisions that have failed to keep our loved ones safe. This includes the failure to robustly implement harm reduction across the country. In Canada, almost all deaths are from unregulated drugs, over 85% nationally. And for opioids in Alberta, it is a staggering 98%. Yet we see political leaders create moral panic around the 2% while ignoring the other 98%. We are told this is an addictions crisis, and more beds, more abstinence-based treatment will be the answer. Yet the example often cited, the Alberta model, has failed to save lives. 2023 will be the worst year on record in death in my home province. According to national data of substance use has not gone up in over 10 years, yet deaths have skyrocketed. Why? This is not a problem of addiction, but of a toxic, unregulated supply. Access to consumption services, drug checking, and to regulated alternatives and decriminalization of people who use drugs is what is needed. Sadly, these measures are currently in place are insufficient for the magnitude of the crisis and do not reach all communities. This is a truth and reconciliation issue. The TRC report calls on the government to reduce gaps in health outcomes between Indigenous and non-Indigenous people, yet Indigenous people are disproportionately affected. They are 7 times more likely to die in Alberta and 5 times more likely in BC. Sarah Auger lost her son Lakota in 2022. He was a doting father, a loving son, and proud to be Cree. He used alcohol and other substances, but his use of unregulated drugs, including the fentanyl that later took his life, escalated only after he was incarcerated. While we know the harm of alcohol surpasses all other substances, one drink will not kill you. Lakota's story and the story of Mike also illustrate the danger of forcing abstinence on people despite the well-documented risks. Mike was the son of our board chair, Tracy Letts. He was playful, thoughtful, and a passionate cook. Both Lakota and Mike died shortly after incarceration. Similarly, Angela Wells lost her young daughter, Zoe, who was athletic, funny, and headstrong, shortly after 2 failed attempts at getting help through the involuntary detention via the Alberta PCHAT Act. What is so upsetting is the fact that the death of our loved ones have become politicized with misinformation and outright lies. This is a public health issue and needs to be treated as such. I urge you to stop the angry, harmful, and misinformed, polarizing debates. Politics and ideology must be taken out of healthcare. Work together and focus on what the evidence tells us. Harm reduction, including the provision of regulated alternatives, saves lives. Evidence-based, voluntary, and accountable treatment saves lives. Prevention and addressing the social determinants of health saves lives. This is not a harm reduction versus recovery debate. Our loved ones need and deserve both. Danny is on my mind every day, and I know he wanted help. The day before he died, he asked me to make an appointment with a psychologist. He did not live long enough to see her. More treatment would not have saved him, but harm reduction and access to regulated substances would have. Where there is life, there is hope. It is your responsibility to ensure that our loved ones live and that we have hope that the needless deaths will end. Thank you kindly for this opportunity.
Thank you, Ms. Schulz. Et enfin,
And we now move to Dr. Marie-Yves Morin. Welcome to the committee. You have the floor. You are on mute right now, Dr. Morin. Now can you hear me? Yes. Good afternoon, all committee members, as well as the expert witnesses who are my colleagues as well. First of all, thank you for having me here today. It is a privilege to be able to share my perspective on addiction and mental health issues among young people. The committee's topic is timely. The WHO has just published an alarming study conducted in several countries, including Canada, on the rise in cannabis, alcohol, and e-cigarette use amongst teenagers. In addition, overdoses of opioids and other substances are the leading cause of death among teenagers in Western Canada. I've been a family doctor specializing in addiction and mental health in Montreal for 20 years, and I currently practice at Clinique La Licorne, and I've had the opportunity to work in various contexts, always related to addictions and mental health. In 2017, I founded Projet Caméléon, a harm reduction NPO. This September, I'm publishing a book about drugs and addictions aimed at young people aged 12 to 25 years, as well as their parents and teachers. In my view, it is urgent to educate our young people frankly about how their brains work and the impact of drugs on them in a way that isn't self-righteous. In my experience, the best prevention remains education, and repression is outdated. Another phenomenon that I've observed since my own adolescence is the explosion in the diversity of drugs available on the black market. When I was in high school 30 years ago, there was no methamphetamine, GHB, MDMA, lean, ketamine, fentanyl, wax pens, ecstasy, let alone opioid or benzodiazepine-based drugs. Drug dealers have no problem in allowing these opioids to get on the market. In terms of teenagers, it is well known that it's often in the family pharmacy that they may have their first contact with opioids and benzodiazepines. Since 2005, I've been giving talks in private high schools mainly because public schools have said they don't have enough money for addiction prevention for their students. Yet, we could truly have an impact on young people if at least the profits from cannabis sales were truly reinvested in prevention, education, and addiction treatment. What we've seen since legalization is excessive trivialization of cannabis consumption among young people and their parents alike. Legal appears to equal trivial. THC is actually, though, an extremely powerful and unpredictable disruptor, even at low doses. Even though they are still illegal due to their very high THC content, wax pens are widely circulating in high schools. In fact, there seems to have been an increase in emergency room visits and hospitalizations for young people with THC psychosis, even though the sale is banned to minors. Not only is legalization far from having curbed the black market, but it has actually driven down the price of cannabis still sold illegally on the street. Like many others, I've observed that the pandemic has had a major deleterious impact on mental health and substance abuse, particularly among young people under the age of 25. They're lacking in passion and human contact. Isolation, the omnipresence of screens, cell phones, and social media, compulsive video games, and the absence of leisure activities have had sometimes catastrophic consequences on the mental equilibrium of these young people whose brains are still developing. What's more, these factors have had a catalytic effect on the development of substance use problems, including alcohol among teenagers, often as a way of self-medicating. It should be pointed out that at least 50 to 70% of addicts also suffer from another primary mental health problem, which was present long before they started using. This is known as comorbidity. As my colleague referred to earlier, for example, a teenager suffering from untreated ADHD may feel relieved and more functional as a result of taking stimulants such as speed or even an antidepressant such as hydromorphine. If all my patients ended up in prison, psychiatry, or the morgue, I wouldn't have been doing this work for 20 years. Many of them get out, become socially functional and independent again, but it takes time, listening, and empathy to identify traumas and treat comorbidities as soon as possible. In my experience, this reduces crime and the harm associated with drug and alcohol use, as well as improving overall health. My humble recommendation to the committee would be to implement concrete drug and alcohol prevention treatment and education measures for all substances, including alcohol, and for all our teenagers in all our schools. Thank you.
Merci à vous.
Thank you.
And now we'll begin with rounds of questions, starting with Dr. Ellis, please, for 6 minutes.
Thank you very much, Chair, and thanks everyone for being here. Dr. Matthew, you talked a bit about comorbidities, and certainly I have a concern with respect to cannabis use and psychosis associated with that. Maybe you could comment on your experience with how prevalent that is in society these days.
Thank you for the question. So for cannabis, legalized cannabis use in Canada, and what we've seen is an increase in cannabis use disorder. We've also seen an increase in ER visits for psychosis related to cannabis. So legalization with cannabis hasn't decreased that. However, there does have to be a balance struck. So has that downside been outweighed by the upside of decreased criminalization of people who are using cannabis? And so I'd leave it to policymakers to decide that. But there does seem to be upsides and downsides for legalization.
And Dr. Matthew, you talked a bit about psychosis associated with methamphetamine use. And in your experience, and if you don't have experience around this, I'm happy to ask someone else, but is it the same type of psychosis you would see, say, with schizophrenia or with cannabis use disorder?
This is going to be a large question, but psychosis is a symptom, and so psychosis is a loss of touch with reality. So these could be fixed false beliefs, which are delusions, or it could be hallucinations, which are false sensory perceptions, or you could have disorganized thought. Now, whether someone has an intrinsic organic psychiatric illness like schizophrenia, or whether they have a substance-induced psychosis such as cannabis-induced psychosis or amphetamine-induced psychosis, it's actually very difficult to tell these apart clinically. And one thing that we have found is that people can have psychosis that is substance-induced that lasts a very long time. So the textbook that we use for in psychiatry, the Diagnostics and Statistical Manual, would describe a substance-induced psychosis as 1 month long. However, with recent research from Shaw et al., what they found is that 80% of cannabis-induced psychosis will last longer than a month. And we know that amphetamine-induced psychosis, 27% will last longer than a month. So it's actually very common for these psychoses to last longer than a month. And then clinically, it's very difficult to tease these two apart. And it ends up being that the treatment is the same. So you would use antipsychotic medication to treat both.
And Dr. Matthew, thank you for that. Through you, Chair, to Dr. Matthew again. When we're talking about making the diagnosis of someone who has substance use disorder and a concomitant mental health illness, let's just put it generically as psychosis, Is it possible to tell those apart when the person is continuing to use their substance of choice?
So there was a study, and the author's name escapes me right now, but what they looked at was folks who came into addiction treatment facility. And they used a scale, it's called the Brief Severity Index, and they looked at different types of psychiatric symptoms such as depression, anxiety, paranoia, and they call it psychoticism. And what they found was that everybody that came into this addiction treatment facility, 39% had psychiatric symptoms. However, 1 month into sobriety, that dropped 13-fold to 3%. And that 3% held steady 6 months out. And so this is what's recommended in the DSM, which I mentioned earlier, is that you should wait a month into sobriety before diagnosing a psychiatric illness. So answering your question, if someone is currently using substances and they don't have a month of sobriety and you don't have a longitudinal history or clinical records, it's very difficult to make a psychiatric diagnosis before they've had that time in sobriety.
Thank you very much for that. And but if I understood you correctly, through you, Chair Dr. Matthew, you would suggest treating that person, for instance, with medication to treat the psychosis, even though they continue to actively use their substance of choice.
Yes. So for antipsychotic medication, what you will find is that if someone has a substance-induced psychosis, and they have an antipsychotic medication on board, the antipsychotic medication won't prevent them from becoming psychotic. Earlier in my talk, I talked about a kindling effect that occurred with substance use. And what happens is, as I mentioned earlier, you'll become psychotic during intoxication, and that extends into sobriety, which extends into, and it becomes more severe. So it actually prevents that progression from happening, and that's the benefit of it. Also, if someone is acutely psychotic, it will help treat their acute psychotic symptoms.
Thank you very much, Dr. Matthew. And through you, Chair, I do have a motion I'd like to move. That motion being that given that Prime Minister Justin Trudeau's dangerous experiment of the decriminalization of drugs such as cocaine, crack, methamphetamines, fentanyl, and more in British Columbia has resulted in a significant increase in deadly drug overdoses and compromised the safety of Canadians, the current drug decriminalization experiment has resulted in carnage and chaos, causing detrimental impacts on public health and community safety. Last week, British Columbia's Premier David Eby has recognized the failings of the experiment and called on the federal government to help them backtrack out of this reckless policy decision. The City of Toronto has made a request to Health Canada asking for drug decriminalization, referring to it as the Toronto model. Drugs would be legal to use everywhere except childcare centres, K-12 schools, and airports. Canadians from coast to coast have been calling for the end of decriminalization, knowing that it is a recovery-oriented system that leads to saving lives, rebuilding families, and eliminating chaos. The committee reports to the House its recommendation that the government immediately dismantle all drug decriminalization programs in Canada. Thank you.
Okay, thank you, Dr. Ellis. The motion touches on the subject matter that we are now considering, so it is therefore in order. Given that we're studying the opioid epidemic and toxic drug crisis, so I rule the motion in order, and the debate is therefore on the motion. Dr. Hanley and then Mr. Doherty.
Thank you, Mr. Chair. This is a really important meeting today. We have 4 excellent witnesses. We've only just begun to hear the testimony. I think the motion, although in order, is not something that we need to debate on right now. What we really need is to hear testimony from the witnesses. I suggest that this is a frivolous motion, and I hereby move to adjourn debate.
Motion to adjourn debate is a non-debatable dilatory motion that must proceed directly to a vote. So the question for the committee is, shall the debate be adjourned? All those in favor of adjourning debate, hands please. 1, 2, 3, 4, 5, 6. All those opposed to adjourning debate, 1, 2, 3, 4. Okay, the motion is adopted. The debate is adjourned. Dr. Ellis's turn is up, and next up is Dr. Hanley for 6 minutes.
Thank you very much, Mr. Chair. And again, thank you to all the witnesses for appearing today. Some very important testimony. Dr. Corderell, I'd like to begin with you. I like, and you've written about this as well, about how responses and solutions may vary by community, and you talk about a diversity of approaches that responds to a community's needs, but also what builds a successful approach as a spectrum of care. Can you talk about a community or an approach that has been successful in integrating the important components, community-based approach, a real example, or perhaps even a hypothetical example of what would actually work?
So I think when we talk about these approaches, often they are places that have had linkages between sectors that haven't traditionally worked together. They're places where you're going to see law enforcement and health working together, where you're going to see cities working with families and different pieces. I mean, a couple of the ones that come to mind, Iceland, for example, was one that tackled very high rates of alcohol use amongst youth. And really what they were able to do was make it everyone's problem. It wasn't just experts. It wasn't just specialists. It was parents. It was school teachers. It was everyone felt that they had a role when they woke up in the morning about contributing to the reductions of the harm, and it was very successful. In France, during a heroin epidemic in the 90s, again, they kind of made it everyone's problem. Every prescriber was taught how to use Suboxone, was taught how to do these different things. So we've actually found through some of our recent conferences and different pieces that with the right supports, you can put people with diverse ideas in the same room, but as long as they're feeling like they're moving forward, as long as they're feeling engaged. And I think a lot of the anger and frustration we're hearing from community members is actually a desire to be more involved in the process. People want to be involved in what is happening in their communities, but they also want to be involved in the solutions.
Thank you. Ms. Schultz, thank you for your testimony, and I'm really sorry about Danny and the approaching 10th year anniversary. I am sure that you must be rehearsing over and over again, maybe 1,000 times or more, what might have happened. But if Danny were here today in that situation, what would be the ideal support that would have helped him survive and thrive even?
Thank you for that question, and thank you for your kind words. With Danny, obviously, he was not at a point where he wanted to stop using. And many people who use substances are not at a time or in the right position to stop using. But everybody deserves a right to live. So at that point, if Danny would have had access to regulated alternatives, that would have not only given him a chance to use a substance that would not have killed him, but it would have also connected him to a health system and opened doors for him and get other support. He also struggled with some mental health issues that could have been addressed at the time. But that would have been a key element. Also, at that time, there was no harm reduction available, which has now been expanded. He was always very safety conscious. Even the day before he died, he had bought fresh needles. We saw that receipt, and it was very hard. If there would have been a safe place to use, he actually died a short walk where we later had a consumption site in Alberta that was subsequently closed. And I can tell you, to those who feel that recriminalization will end public substance use, I invite them to come to Alberta. there is a lot of public substance use happening because we have closed safe places. And as long as we don't have housing and as long as we don't have safe places for people to use, we will see public substance use. And we also see people like Danny using home alone. Another thing that would have helped Danny is decriminalization. He was very aware of his substance use, and he felt shameful. He felt it was causing our family shame and stigma. Stigma is a huge issue. We often talk about stigma, but you will not remove stigma until you end the criminalization of people.
Excuse me, but I do, because I only have a minute or two left. I want to just no, but that's fine. This is fantastic. Thank you. Was criminal use of drugs? Do you think that was a factor in Danny's death and Olivia's death that you described? Yes or no?
It was most certainly a huge factor. The fact that he only had access to unregulated substances and that he felt he had to hide his use. His dream was actually to join the army. That was one thing he wanted to do. And he knew that having a record of substance use would have prevented that. So he very much wanted to hide that from the public eye, but also from his family, which ultimately meant he was alone when he died.
Thank you. And in the brief time I have left, I'm following up on Dr. Cardarella's comment. There's a bit of an us and them. How do we help to augment the idea that this is everybody's problem? This is a problem for all of us. In your mind, Petra?
Thank you. I think we have their attention. We have people's attention. It's not an awareness issue now. And really, this comes down to people knowing and believing that we have both the evidence and the data to move things forward. I think this is where I've become increasingly a fan of community coalition work, which is an evidence-based, especially prevention tactic to try and raise people. So I don't know that people don't want to be involved. I think right now it's that they don't know what to do. We know there's a lot of things that work, again, because prevention, treatment, recovery, harm reduction, but I don't think they know what their role is to be. So how do we set up that skeleton? How do we support them? Realistically, a lot of these things are tremendously cost-effective. But
Thank you, Dr. Cardarella. That's all the time for this round. Ms. Thériault.
We'll now move to Mr. Thériault for 6 minutes. Thank you very much, Chair. And thank you to all the witnesses here today for their testimony. My question will be for Dr. Morin. It's been 20 years since you started working in harm reduction strategies. I don't want to take too much time because I only have 6 minutes. I mostly want to be able to listen to you, but there are several witnesses who said before this committee that given this crisis of illicit contaminated drugs and given the deaths from this epidemic, something had to be done. So, for example, safe supply. But now we're seeing that supervised injection sites or supervised consumption sites are problematic for people. So based on your experience, your 20-year experience in harm reduction, you're saying that we have to work upstream even further in prevention. However, should we go as far as recriminalizing? Because earlier on, you spoke about the failure of decriminalization to a certain extent of marijuana. So I want to hear what you have to say about that. You are on mute, Ms. Morin. Apologies. Thank you for the question. It's an excellent one. I could talk to you about this for about 3 hours. I think it's very important to be frank when you're talking about people with use. Harm reduction is part of a strategy, but it's not an absolute solution. And there's also the issue of comorbidities, when we know that 50 to 70% of those who have addictions have another mental health issue. It could be ADHD or bipolar, and about 50% at a minimum of those who are addicted to opioids suffer from chronic pain. So when you're talking about comorbidities, whether they be physical or psychiatric, it's much less difficult for a person to reduce their use when they're treated as someone having a comorbidity. I worked for 4 years in federal prisons, and I saw that 80% of inmates, federal inmates, had a conviction or had been arrested related to drug or alcohol use. So when we're talking about decriminalization, what I think is that exposure tends to increase consumption. Decriminalization, I thought a few years ago, was a little more realistic, but now I'm not so sure. I'm not sure that we're ready for that. And what I would add is that it's a bit of a paradox that there are so many deaths from opioids when we know that that's the only addiction that you can actually treat. We have methadone, we have hydromorphine. And when you prescribe that at the right levels, it can stop that consumption of opioids. So I think you have to go and look at resources in psychiatry, general medicine, in order to be able to treat, for example, chronic pain. Harm reduction is one step, one stage. Any alcoholic is going to try and stop, and several times before being able to stop. So harm reduction is a way of bringing some of these individuals to abstaining or at least reducing their use eventually. But we have to be able to treat comorbidities. That's what I've seen in my practice. But harm reduction for me is not a religion. It's one tool. And sometimes that's not the tool that is needed. I think it applies to all addictions, but it's not an absolute single tool. Harm reduction is one tool. Yes, I understood your point. So you're saying that we need to intervene earlier in prevention, but there are taboos linked to use, to substance use. People are going to use recreationally because it's fun, because it's good, and that's good. They feel good, and we don't talk about that. So how do you talk about prevention then? Well, 25 years ago, maybe that was truer. There were less drugs available, and those that were on the market were actually good quality. I mean, I hate to say it, but they were. But today there's contamination. There are so many more drugs, and then there are all these mixed substances. So I don't know a lot of people who are just addicted to one substance. These are people now who are addicted to several substances at a time. That's what I've seen on the ground. And as I said, I think harm reduction is one tool, but it's not going to solve everything. I think you have to go back to the basics and treat comorbidities. Thank you. Well, let me take Vancouver, for example, where public use is an issue, and the authorities want to be able to have greater control over this. Now, I understand the idea behind this. However, should we go as far as legislation, as a law? When municipalities, for example, could have bylaws that would give enforcement services the possibility of acting, and that way there wouldn't be the same stigma attached to use. Because sometimes, I mean, it's been mentioned that there were people who were using in waiting rooms, for example, in Montreal. Well, you know, it happens everywhere, in public toilets, everywhere. But I think it will be difficult to backpedal now. I don't want to be pessimistic. We've opened up the doors. I think it's very difficult to close the doors. I don't know how we're going to move forward, but I think we're going to need more social workers, more psychologists, more people who are working actually on the streets to help, who have expertise in therapy and social work. You know, it's like saying people are allowed to go faster than the speed limit. Everyone tolerates it, but it's not allowed. So it's going to be very hard to go back, and we have to treat mental health, we have to treat comorbidities, and we have to deal with the criminality associated with this criminality that may be happening because of psychosis, for example.
Next, Mr. Johns, please, for 6 minutes.
Well, thank you to all the witnesses for being here, and speak to Ms. Schultz, and first, again, extending my condolences as well for Danny and for on the eve of the anniversary of his death. You and the mothers and families know better than anybody how dangerous the toxic illicit drug supply is right now, and what it's like to support someone with substance use disorder. We've seen, the numbers in BC somewhat plateau at about 5% over year in terms of growth in overdose deaths. No growth, no overdose death is good. We've seen Ontario at 6.8%. They also have safe supply there. It's a very small amount in both provinces, less than, I think, 2.5% of people that have substance use disorder. In Alberta, the numbers have shot up 17% in your home province. Saskatchewan, 23%. A neighboring state, Alaska, a Republican state, 45% year over year. They've just surpassed BC for toxic drug deaths per 100,000, and Alberta's on a trajectory to pass BC by June. Can you tell us what's going on in your home province? Why such a spike in Alberta, Saskatchewan, and possibly Alaska?
What is happening in my province is heartbreaking. We've seen a government with a myopic focus on treatment, and trust me, treatment is important. We love treatment. We love recovery as families. But we have to make sure that people are well and alive. And even within that treatment model, it's been in place now. A recovery-oriented system of care has been in place for 4.5 years. Yet, as you outlined, we have some of the highest increases in the country. Yet, if you do seek care, I recently tried to get somebody into detox. You have to show up at detox 3 days in a row at 9 o'clock in the morning to get the person in. Explain that to somebody using stimulants, that you will get up early and go with me 3 days in a row, and maybe on day 3 I get you in. The recovery community in Red Deer has a 6-month waiting list. My dear friend Esther Tailfeathers is from the Blood Tribe in southern Alberta, where the government closed the consumption site. Lethbridge now has a per capita rate that is 3 times that of other community. It was the only site that had inhalation, and more people have moved to inhalation, and we don't provide these services throughout. In southern Alberta, in Lethbridge, the Blood Tribe was promised a recovery community. They have 3.5 years ago, they have one ceremonious shovel in the ground, but no building forward. So not only is there this myopic focus on what is called recovery, but it's in name only. It is actually not available to people who need it, where the drug supply is getting more toxic. And you see it in the increases. For me, the true measure of success of any policy approach is when my friends don't have to arrange funerals. That is a true measure of success. Our board chair, Tracy Letts, is just planning the future funeral for her son. As long as this is going on, the model is not successful, and Alberta's model is failing us. So when people push recovery without harm reduction, without addressing prevention, nobody's talking prevention anymore. I'm glad my fellow speakers have raised this point.
So, we had the BC police chiefs here. We had the deputy RCMP commissioner here. They were very clear in terms of the decriminalization model in British Columbia, which has only been going for 18 months, that they wanted tools to be able to move people along. They were also very clear that they cited Ms. Wilson. She said, we all agree that we do not want to criminalize people by virtue of their personal drug use. Those days are gone. We want to support a health-led approach. They're very clear that they don't want to go back to criminalizing people. They also cited they're not dying from diverted safe supply. They're not actually dying from diverted prescription medicine. They're dying from fentanyl, coke, meth, and that's where we really want to focus our enforcement efforts. They also called for more safe consumption sites and expanding them to include inhalation. And they also made it clear that this is not just a law enforcement issue. It's a public health crisis that demands a compassionate and comprehensive response. And lastly, the RCMP continues to support all efforts to ensure that an overdose emergency is dealt with as a health and medical emergency. So when you hear that and you see a testimony and politicians come out of a hearing like that, and they want to attack decriminalization and call it as the root cause, or safe supply as the root cause for this toxic drug crisis, how does that make you feel as a mother of a lost loved one?
I feel anger, I feel frustration, but I also feel disbelief how somebody who is the leader of a national political party can share information that is not factual, share information that does not align with what is actually happening on decriminalization or on safe supply. I urge you all to look at the evidence that shows the effectiveness of those measures, and that's where we have to focus back.
Very short question. Have you met with all of the political leaders, Mom Stop the Harm, in this country? And if anyone's missing, why?
Mr. Polyev is missing. I've reached out to him again, saying that we tried a year ago to meet with him. We've written to him several times. I saw Minister Sachs this morning. She made time with you. I know I can reach you when I need you, but Mr. Polyev has not heeded our calls for a meeting. We'd very much like to talk to him. We'd very much like to tell him what we feel about families, what we experience. We live this every day, every day. And it is time that he open his door and engage with dialogues with families who represent thousands of Canadians who have suffered this loss.
Thank you. And that's all the time for you, Mr. Johns. Next, Mr. Doherty, please, for 5 minutes.
Thank you, Mr. Chair. Ms. Schultz, I appreciate your testimony here today. I don't know whether you've heard my testimony, my interventions here. I have a brother that lives on the street, is addicted to drugs. I've lost a brother-in-law to overdose, and matter of fact, I've many family members that are addicted to drugs, and it is when you're living it every day, you don't know when that phone rings if that's going to be the day that you hear that your loved one has been found dead, my brother or brother-in-law. So we relive that each and every day. Our leader has been very clear that we believe in recovery. We believe that if somebody like yourself or your son was ready for treatment, that a bed is there. You don't have to wait 6 months. You don't have to show up 3 days in a row. That's what our leader believes in. And so it can be spun every different way. I do want to thank you for your testimony today. But I want to ask you, do you believe that we should have safe supply of hard drugs like heroin, cocaine, crack, or meth on the streets?
Not on the streets, no. But that is not what anybody is proposing.
Should we instead invest dollars in having a recovery, like a bed for recovery? If you need it, it's there.
It's not an one or the other. We need both. My son wanted treatment. I made an appointment with his counselor and with his doctor, but he was dead the very same day I made the appointment. If we don't keep people alive and well, we can have all the treatment beds. They will be empty when everyone is dead. And with treatment, it has to be a choice. It has to be evidence-based. If we focus on abstinence only, the guidelines from CRISM tell us that opioid agonist treatment is what is most effective. And the streets are not paved with safe supply. In Alberta, 98% of the deaths are for opioids are from unregulated drugs. 2% from regulated substances.
Dr. Matthew, can you explain to this committee your concerns regarding the government-funded so-called safe supply?
Sure. So one thing that we should look at is the supply of opioids in a population. And so if you look at 2020 and the countries that had the highest overdose rates, the number one country was the United States of America. And I think it was around 271 deaths per million population. And this is also the country that had the highest supply of opioids in the population. So fentanyl is an important aspect of this, but how do people end up overdosing on fentanyl? So oftentimes the story is people started with legal substances that have been prescribed, then they become addicted, they get a tolerance, and then that no longer works for them. And so then they shift to the illicit market at that point, and because they need something stronger. So I talked about 2020. Now, in 2020, the overdose deaths in British Columbia were 340 per million. And so it's much larger than what's occurring in the United States. It's much larger than any other province in Canada. So as of last year, that's gone up to, I think, 444 per million. So there's been a massive increase as well. And this is what I worry about, is the supply of opioids in the population. So, sorry, go ahead.
In your opinion, will decriminalization and so-called safe supply fix our opioid crisis?
So I'll start with decriminalization. So if you look at decriminalization, there's different models for decriminalization. It's important to distinguish the two. So, for instance, you had a model like Oregon, where it was very similar to what they did in Vancouver, where they allowed public drug use. And what they found was that between 2022 and 2023, there was a 45% increase in overdose deaths. And that was the highest increase of any state. And that's why this March, Oregon repealed their decriminalization. Portugal had a different model. What they did for decriminalization was people either faced legal sanctions or they went into treatment. So there was sort of a coercion into treatment, and that's the shift that Oregon has made. And I actually commend the BC government for when they found more information, they were able to pivot as well. And then regarding, sorry, go ahead.
Thank you. Sorry with that. You took a pause at about the 5-minute mark and allowed me to jump in. So you'll get I'm sure that you'll get a chance to expand upon your answer. Thank you, Mr. Doherty. And next, Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, all the witnesses. Thank you, Ms. Schultz, sharing Danny's story. No mother should go through which you went through. So my question is that the opioid crisis affects people from every walk of life. Given the stigma attached to substance use, we can understand why some professionals, people in school, or with families are afraid to even admit they're using drugs. Could you expand on this, why it's important to remove stigma and barrier of care?
Thank you for your kind words. Stigma is a barrier to getting help. As long as substance use is as deeply stigmatized as it is now, people will hide their use, and we know that men are disproportionately affected among the victims. About 80% are men. Stigma makes it harder for people to reach out. And if any measure that we take to reduce the stigma means that people feel more open to even discuss it with a friend or a family member, for a student to reach out with a teacher. And nothing stigmatizes people more than the criminalization of substance use. We know that the criminal record affects what you can do for education, where you can travel, where you can live, what you can study. And that is just such an enormous barrier that we can remove with decriminalization.
You talked about the education. So what age, education need to be started, the awareness for drugs?
It should be age appropriate. I'm an educator, and I get this question a lot. We should discuss substance use when we discuss other issues young people need to learn about, like how to address alcohol, safe sex, and not separate it out. Put it in the entire package of when we discuss with our young people how we keep them safe. Of course, at an age-appropriate level, and we should focus on, as much as possible, reducing abstinence is always a goal when we talk to young people. But when we take a harm reduction approach, that also means they stay safe. Like we all know, we'll never get all teenagers from abstaining from having sex, but we want them to be safe. At the same token, we want teenagers to be safe if they use substances.
You have been a strong advocate about a person-centered approach of care. What do you think about that and community-led approach for youth? What do you think about those approaches?
Community-led approaches are really important because the community is not only the ones that has the experience, they are also that can carry it forward. That is why it is so important to include affected communities. And what is also something not often talked about, that in some of our communities in Canada, substance use is even more stigmatized. And to take the messages into these communities, also in different languages, and with people from the community. That is important.
You also talked about the misinformation. So you want to elaborate there? What kind of misinformation is?
Well, for example, to say that people are, that the streets are plastered with safe supply. They are not. Alberta shows you that even in British Columbia, we hear that from the chiefs of police, we hear that from the chief coroner. Safe supply is not what is killing people. Unregulated drugs are, and that is something that we hear over and over again from certain corners, that people are dying because of safe supply. The other thing is that decriminalization causes social disorder. When people are unhoused and have no safe place to use, they will use in public. In British Columbia, Alberta, in Ontario, or any other province in this country, or territory, apologies.
Thank you. And Dr. Cardrella, I have a question for you. What type of treatments or services must be available for individual using substances in response to physical or sexual abuse or any form of trauma?
Thank you. So in healthcare, we talk about trauma-informed care, this idea that essentially not everyone will disclose their trauma to begin with. So being kind of opening that door and treating everyone in a way that is sensitive and appropriate. And I think we probably need something fairly similar when it comes to substance use. And making the assumption that any person could potentially have a substance use disorder and may need some help. This is where, again, I think understanding, people want to be resilient. People want to be able to bend and bend back. And I think being able to build that out is probably one of the most important things we can do for people from a trauma-informed lens. We need to be having a lot more conversations about how we build skills. And so even when we talk about some of these prevention programs that, for example, have done amazing things like reduce by half the initiation of drugs or alcohol, it's really about skill building. It's about building communication with families. It's about helping people survive better in the world. So more than anything, it's about being able to meet people at the moment that they are. Thank you.
Thank you, Dr. Cardarella. Ms. Sidou, souhaite M. Thériault pour 2 minutes et demie, s'il vous plaît.
2 minutes et demie. Thank you, Chair. Dr. Morin, earlier on, you said that one should be careful about having ideological positions with respect to strategies. I agree with that. I'm going to give you my 2.5 minutes to speak to this. You spoke about teenagers. You said that we need prevention. I'm giving you my time to speak to them. What would you say to these adolescents before they show up at your clinic so that they don't end up there? Well, I've actually been doing that since 2005. I go to schools. Earlier on, someone said, at what age should one start? Well, I would say that by 12 years old, you need to have started talking about drugs and sex. Young people are intelligent. They shouldn't be underestimated. When you explain to them in clear terms what the potential harm and toxic effects are of these substances, they can understand. Do you know, we all have to be able to make enlightened choices rather, and I don't think enough young people have been enlightened enough, and they can be through explanations. Earlier on, we were talking about skills. Well, young people are sponges. They can learn. And the thing is, we're not doing this. It's all about, repression or punishment, but we need to educate them. Yes, certain substances, of course, can make you feel pleasure, but there are associated risks. For example, MDMA can lead you to panic. It can lead to various neurological symptoms. With cannabis, you can end up going into psychosis, and with opioids, we know it can happen as well. You don't get a second chance with opioids. Yesterday, I went to the funeral of my favorite patients, and they died from a fentanyl overdose. Yet, that individual had been injecting for 20 years. So we're not even just talking about beginners or experience. I think in that case, it was really bad luck. But people are much brighter than you might think. And if they're given clear explanations, they can make a decision. I think oftentimes people are ignorant, and oftentimes they act through peer pressure as well. They try and rise to the challenge. Sometimes also they see their favorite artists and celebrities using, for example, their favorite rap singers, for example. We all have our idols, of course. We've all had them. And they all have their habits. But I think some of these things, some of these more dangerous things are actually being promoted, including benzodiazepines and opioids, promoted by some, which means that young people need to be educated as early as 12 years. They're able to understand. Have I already run out, Chair? Yes, you have.
Mr. Johns, please, for 2.5 minutes.
Thank you. We heard the expert task force on substance use from Health Canada. They made it very clear, unanimous recommendations to support decriminalization, safer supply, treatment on demand, recovery prevention, education, scale up, all those areas. They were unanimous. They had the Police Chiefs Association, health experts, Indigenous leaders on substance use, people with lived and living experience. The Police Chiefs of Canada put out a report that reflected that as well. Portugal delivered a model of that included a coordinated, compassionate, and integrated approach. We right now have a government that's taking an incremental approach in a public health emergency. We have politicians that are spreading disinformation in the middle of a public health emergency. Both cost lives. And I don't appreciate being heckled here at this committee, Mr. Chair. Secondly, we put forward a bill, Bill C-210, to take a health-based response to the toxic drug crisis, hoping that it would get to committee and at least have an opportunity to be looked at. We have had an auto summit on theft of autos, which is, of course, an important issue, but this is the leading cause of death in my home province under the age of 59. Still nothing. We have not had the government declare a national public health emergency. We're glad today in question period, under our pressure, to finally see that they're going to reinstate somewhat of a form of the expert task force on substance use. That's a relief. But Portugal, what they did is they implemented their expert task force, and the politicians, where they were heroes, they got out of the way. They let the experts lead instead of ideology. Can you speak, Ms. Schultz, about the importance of listening to the experts and letting evidence-generated policy lead versus ideology in politics, and how that's costing lives?
We see it again with the Alberta model, how that is failing, because Alberta has chosen to keep a focus only on a narrow scope of opinions, whereas when we let the experts lead, we look at all the available evidence and follow that. Having experts lead means that we can have people who are in the room, people who use drugs, show us what works for them, what is effective. And that is what has also happened in other countries. I was recently at the United Nations Commission on Narcotic Drugs, where I was amazed that the US put forward a policy that had the words harm reduction in it. For the first time in the history of the United Nations, harm reduction was one of the pillars that was included. Switzerland talked about how they continue to provide safe supply. So the world is moving in that direction. Canada cannot move backwards.
Thank you, Ms. Schultz. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for taking your time to be here today. I'm going to start out, Dr. Matthew. In 2021, you published a piece in the British Medical Journal based on some discussions you had with a convicted drug dealer in BC. And the person said that many people who use drugs seek out fentanyl. And he even said that when people see someone overdose, they want to go buy off of that person's dealer because they know they'll get the stronger, better stuff. And this seems to indicate that people seek out stronger drugs as opposed to, quote unquote, safe drugs, even if they know that it could kill them. I was wondering if you could explain this a little bit.
Sure, thanks for the question. So something that would worry me is that what is provided will not be able to compete with the illicit market. So the illicit market is often described as a poison drug supply. From the data available, it seems that the market is supplying the demand of the end consumer. So when Paul Janssen invented fentanyl, one of the reasons was that it would have a fast onset and offset. So for the end user, this means that this drug does not have legs, meaning that it does not provide the end user with the duration of intoxication that they seek. As a result, in BC, roughly 50% of the drug supply has another drug, type of drug, it's called a benzodiazepine in it, that would provide the duration of intoxication. This makes the drugs provided more toxic. Because we have to think of safety, I'm skeptical that we can provide legal forms of drugs that the end consumer will use to displace the illicit supply. Going to your question, I think it'll be difficult for the legal market to supplant the illicit market because we have to think of safety. And I think that the end user, for instance, if someone overdoses and passes away, more people will actually go to that drug dealer to buy drugs from that person because they have stronger stuff, and that's what's sought after. Safety is not what's sought after as the primary end goal of the end consumer.
Thank you. I appreciate that. Dr. Cadrella, one of the main arguments that's been used in the proponents of the so-called safe supply is that it will offset the illegal market and the black market. I was wondering, we actually have a bit of a case study here. Cannabis was legalized 6 years ago. So approximately what percentage of the market in Canada today is legal versus illegal?
Thank you for the question. So one of the things we struggle with a lot in this country is knowing exactly how much people are using and who's using what. It's one of the issues, for example, around opioids too. We don't actually know how many people are using opioids in this country. When it comes to cannabis, there have been a few estimates, and to the best of our knowledge, it seems to be that the legal market in the past 5 years has captured probably about 50 to 60% of the black market switching over, with price being one of the big factors as well as availability.
Thank you. I appreciate that. And I think this is all part of this proof point that if we're going off of this as if somehow people are choosing these drugs because they're safe, addiction is a medical condition and people aren't necessarily making the logical decisions that we would hope they make in these situations. And so this is part of the challenge. Dr. Matthew, you're on the ground in British Columbia. How do you think that the request from the Premier of British Columbia to roll back a lot of the decriminalization is a good decision or a good request?
I think taking all the information in and comparing what happened with Portugal. So again, in Portugal, it wasn't a public drug use that was allowed. It was you'd either face legal sanctions or you'd go into treatment. And seeing what's happened in Oregon as well. And also seeing what's happened in British Columbia, overdoses have only increased with decriminalization. It's an intervention that's been placed on the entire province, and we haven't seen the outcomes. So I commend the Premier for pivoting once he's had more information.
Thank you. So considering this, Mr. Chair, I'd like to move a motion that I put on notice last Friday that given a statement from the Office of the Federal Minister of Mental Health and Addictions and the Associate Minister of Health states that there will be a meeting with British Columbia's Minister of Mental Health and Addictions to discuss drug decriminalization, and that 3 municipal councillors within the Greater Vancouver metropolitan area have indicated they will bring motions to their respective councils to formally call on the province and federal government to end the decriminalization pilot, and pursuant to that we would like to see, pursuant to Standing Order 1062, the committee add an additional 2 meetings to the study of the opioid epidemic and toxic drug crisis in Canada to discuss decriminalization, and that the Minister of Mental Health and Addiction and the Associate Minister of Health Health Canada be invited for no less than 2 hours, and British Columbia's Minister for Mental Health and Addiction and DJ Larkin of the Canadian Drug Policy Coalition be invited for no less than 2 hours. I think it is absolutely incumbent on us as legislators, when we've had such a huge development happen in the last few weeks when it comes to the conversation around decriminalization, that we actually look into this. And we haven't heard from the federal government where they're at. What we have heard is the Minister of Mental Health and Addiction say that she is not planning to take any immediate action. We have heard that the police in British Columbia do not have the tools they need to keep people safe. We have heard that addictions have gone up. We have heard that overdose deaths have gone up. We have heard that there is crime and chaos and disorder running rampant in our communities. And so I think it is absolutely incumbent on us, especially as we've been undertaking this study, to continue looking into this, because this has developed quite quickly since we had Fiona Wilson, the Deputy Police Commissioner from the Vancouver Police Department, come in and state that they had no tools to be able to do their job. And so I would ask that we be able to have this study go forward, expand this so that we can have those ministers come in and explain from their perspective how we should go forward in this, so that we can make sure that all Canadians are safe and that British Columbians are safe. There are 6 people every single day that die in the province of British Columbia due to overdoses, and it's incumbent on us that we're taking